Hi, I'm Wykeshia Farley, and this presentation is on catheter-associated urinary tract infection prevention in the rehab hospital. Catheter-associated urinary tract infection is one of the most common infections a person can have in the hospital, according to the American Association of Critical Care Nurses. It is also one of the national patient safety goals. Our goal here is to use proven guidelines to prevent infections of the urinary tract that are caused by catheters. 7 to 80% of catheter-associated urinary tract infections are contributed to indwelling catheters. These are some statistics related to cauda. As we said before, it is one of the most common hospital-associated infections. About 12 to 16% of patients that are in the hospital will have a urinary catheter at some time. Cauda rates reported in 2011 reported there were 0.2 to 4.8 per 1,000 catheter days for adults in inpatient units. 1.5% of catheter days are reported in trauma. Cauda also increases the morbidity and the mortality rate in patients. It increases the length of stay, and it increases the cost to treat the patient, and it leads to unnecessary use of antimicrobial. These are some risk factors that are associated with cauda. The ones indicated in red are modifiable risk factors: prolonged catheterization, disconnection of the drainage system, and lower professional training of the inserter. One of the main goals is to target the modifiable risk factors. We want to tackle prolonged catheterization. For every catheter that remains in place each day, it increases cauda by 5%. And the number of patient days decrease with the indwelling catheter if we can assess for necessity each day and if we can indicate the nurse-driven protocol. Another modifiable risk factor is disconnection of the drainage system. We want to limit the times we have to disconnect the drainage system for anything. Keeping a closed system will prevent any infection. And training of the inserter is very important. We want to make sure that the person installing the indwelling catheter uses the proper technique and maintains sterile upon use of the indwelling catheter. Here in the rehab hospital, upon hire and annually, nurses are trained and they have to demonstrate proper use of inserting the Foley catheters. One of the big questions that we need to ask when we have patients with a Foley catheter: is it really necessary? We only want to leave catheters in place as long as they're needed. Our goal is to remove them as soon as possible to reduce cauda. The nurse-driven protocol helps us do this. The first step is to make sure upon admission that we use the protocol if there is a patient that has an indwelling catheter. There are 4 steps in the nurse-driven protocol that we use. Each step indicates the next step and what you should do in the protocol if you have an indwelling catheter. If you have to remove the catheter, these are some things that you want to do. If the patient voids within 4 hours, greater than 400 milliliters, you want to make sure you continue to monitor the patient every 2 hours for 8, and then Q4 hours for 24 hours. If the patient voids within 4 hours less than 400, or if the patient is incontinent, we want to bladder scan the bladder to make sure that they're not retaining. If they are, you want a post-void residual greater than 400. If that is so, we want to make sure we straight catheter into the bladder. If it's less than 400, we want to initiate prompted voids. If we don't get a void within 4 hours of removing the catheter, or the patient is uncomfortable at any time, we scan the bladder to see how much is in. If it's greater than 400, or if it's greater than 400, we want to make sure we straight cath. If it's less than 400, we want to monitor hourly for spontaneous voids. And PVRs are post-void residuals. There are some acceptable indications for use of indwelling catheters. We use them for 24-hour urine collection on patients that are incontinent. We use them for bladder obstruction or urinary retention when there's no other means. We also use them for eyes and nose, strict eyes and nose for critically ill patients. And if they have a wound or perinatal wound that needs to heal and the patient is incontinent, we insert a catheter to promote healing. We also use them for patients that are immobilized due to trauma. We use them for comfort care in a terminally ill patient, And we leave them in place if urology has placed them and has designated not to remove them. Only catheters meeting the criteria above should be left in place. It is the nurse's responsibility to reassess every shift whether the catheter is still meeting criteria to stay in. And we as nurses must document this every shift. If you do have to have an indwelling catheter in place, there are some things we can do to manage this to prevent caught-out. First of all, it's proper utilization, making sure that we meet the indications for it to be in place. Alternatives, making sure that they have been considered before we leave the catheter in place. And if we're going to care for the catheter, make sure we use gloves and proper hand hygiene. Also, you want to make sure that your staff is trained, as we stated before, making sure they use sterile technique and make sure the material is sterile as well. We use stat locks to keep it from shearing or friction or tearing. A closed drainage system is what we use, and we try not to break the closed drainage system at all. We want to make sure that the urine is flowing at all times, there are no kinks in the tubing, and that there's free flow of the bladder. Whenever we have peritoneal care to the patient, we want to make sure we use soap and water daily. And on new admissions, if they come in with catheters and they have to maintain the catheters, we always insert a new catheter on admission. And if we have to obtain a specimen or to irrigate the bladder, we want to make sure we clean the port of the catheter. We use HCG and alcohol prior to obtaining it. Some things to think about for your alternatives for indwelling catheters. Bladder training programs. You can toilet the patient every 2 hours. Intermittent cath, ICP. Patients with neurogenic bladder or urinary retention can be put on the ICP program. Bladder scanning to check for residual to make sure that the bladder is empty. Condom catheters for males to make sure that there's no urinary retention or obstruction. It is our job to make sure that we use every attempt at alternatives to using catheters. Our first phase of the plan is education. We always want to make sure that we educate. The nurses must be educated on indwelling urinary catheters, on caught-out, what the cause of caught-out and how to prevent it. We want to educate the patients and the families on the importance of bladder management, on signs and symptoms of infection and infection prevention. And we use the indwelling catheter user indication through the nurse-driven protocol to make sure that we have a need for the catheter. And we want to make sure that we track the compliance of use of the protocol and make sure it's effective in helping us prevent caught-out. One of the things that we've done is added a question set to our daily shift assessment for us to indicate whether or not the Foley is still indicated for use. Patient activation and patient engagement, that's a huge thing for us. We want to make sure we continue to educate the patients, make sure we educate them on catheter care, make sure they know what it means to have correct hand hygiene and to what the signs and symptoms are of urinary and bladder infections. These are references for the information in the slide on caught-out. Are there any questions related to this?
What role does physicians have other than saying start it or stop it? Is it just the nurse's responsibility?
It's both the nurses and the physician's responsibility when you're using a nurse-driven protocol. If you have a Foley in place and you use a protocol that indicates use forward, then you want to make sure you follow physician orders. If your indications do not match and you still have a Foley catheter in place, then you can initiate the nurse-driven protocol for ordering your physician to remove the catheter. Have any other questions? Thank you. This is the end of my presentation.